Hi, everyone. It's 1 o'clock, but it looks like people are a little behind logging on today. So let's just wait for a couple more minutes and then we will get started. I have a couple messages in the chat, so everybody take a look at the chat. And Marcia, as usual, will you send me an email about who's in the room with you, please?
I will.
Thank you. Okay, it looks like we've got a good group here. We'll probably have a couple more people make their way in, but this is the final in the training series with the Collaborative Family Healthcare Association. And thank you so much, Martha, for everything that you've done for us. We appreciate all of your hard work and engagement. I do have a couple of messages in the chat. If you're a psychologist seeking CME for this webinar series, please be sure to email me and let me know that you filled out all of the surveys. If you don't know if you filled out the surveys, you can let me know and I can go in and check for you. And there's one more survey coming tomorrow. And I'm going to turn it over to Martha. We have a new staff member, Renee Sutke, who's joined us. She's going to be sharing the slides for you, Martha. So we're going to kick off the meeting.
Great. Thank you so much, Jen. I just want to emphasize that it has been a wonderful year sharing with all of you every month and sharing my passion. And I hope it continues to be a passion not for you guys, but also in your own sites regarding integration. So I also want to let you guys know that we still are open for those one-on-one consults. So feel free to email Jan so she can share my email, or you guys already, some of you know my email, just email me and we can schedule a Zoom meeting for those one-on-one support for each site. So today, the last topic is substance abuse, and we're going to be talking about two clinical pathways. It's the SPIRT and MAT regarding to substance abuse. So we can go to the next slide. And if you guys remember, for those who have joined us since the beginning, we started our very first presentation talking about the two models that we already kind of explained in regards to integration, which is the PCBH model and the collaborative care model. But below you see in these three that we talk about that there was clinical pathways. And this slide, again, you probably will remember, it was one of our slides just to kind of help you map out and visually see how we're going to be going forward with this training. Now, I want to emphasize that a lot of people will ask me, well, what is the best model to use, or what is the best clinical pathway to use? And reality is that what you want to be asking yourself is what type of questions you are trying to answer in your site. So for example, if in your site you're having accessibility issues in which a lot of people need mental health support, or even your providers are feeling burnt out with the issues they're dealing with, which is not just medical issues, but they're having troubles with patients having adherence to medication or healthy behaviors or mental health struggles, then probably the best model will be PCBH. Now, if in your clinic, it's more like you want to target a particular group of population in your clinic, let's say track the improvement of kiddos with ADHD, or track a particular group of people with depression and anxiety and track how they kind of improved, that probably will be the best thing will be to use the collaborative care model. And the same goes with substance use. So I want you, as you hear this presentation, to start thinking about what does really my site need in this area? And then that can be easier for you to identify the pathways that you can use. We can go to the next slide. So we're going to be talking first with the SBIRT, which is marked on red there. But if we go to the next slide, those words, I will say not those words, those letters, it's actually the acronym for screening, which is the S, brief intervention, which is the RI, and then referral, the R, and then for treatment, the T. So it really stands for you're going to screen the situation with the patient. You're going to provide a brief intervention if it's needed. And if actually the patient needs more further support, you're going to refer for treatment. So that's really what this pathway of model, clinical pathway stands for. So what really is to identify, particularly in the early stages, if someone is struggling with drug or alcohol. A lot of the times what we have found out while we start with the screening process is that we find ourselves as providers giving a lot of psychoeducation because the patient does not see that they have a problem and is not. So when you ask, oh, do you have any problem with drug or alcohol in a regular, visit, they will say no, because in their life and in their minds, that's not a problem. But it's not until we put a screener and we see a lot of yeses or positive questions answered, we realize that actually the patient does have a problem or is starting in an early stage that if this unhealthy pattern continues, it will be unhealthy. But the patient at that time doesn't know. So this is very important because we're able to, in early stages, identify if there's a problem and provide psychoeducation. And also, sometimes, these are questions that very openly patients will not talk about it. They feel, ashamed or afraid of, sharing with you if they're using any drugs or alcohol. So it's hard to identify. But screeners will help us realize if we're dealing with a problem here. So the two screeners that we usually typically do, but again, it depends on your site and the clinical flows that you have, but the most high use are the audit, which is for alcohol disorders, and the DAS, which is for drug abuse screening test. If we go to the next slide, I actually place here, for those who are not familiar with, the audit screener, which is for the alcohol screener. And then there are 10 items or questions that either female or male will answer. And then the way you actually are going to evaluate is going to look different. So if we go to the next slide, I actually also included the scoring of this screener, because you're going to see that it's going to be different between women and men. And it's very, very basically had to do with the physiology of, between a female and a male. So it will come positive, or we will highlight that there's a problem for a woman when they're drinking probably the same amount of, let's say, their partner, right? Like, oh, we drink the same amount. Why he's not has a problem and I do? Well, actually, it has to do with the complexity of the body, but it's scored differently. So again, this is a screener that we use in order to identify if there's a problem. I can tell you that I'm going to share a story with you. So years ago, I have a Hispanic Latino male who answered this, came out positive. And when I came, so then the provider told me, and then I came into the room with a warm hand up. And when I started talking to him, in his mind, there was not a problem. Because reality was that he was drinking a lot. Well, he was drinking, I would say, moderate throughout the days of the week, but on the weekend he was drinking excessively. However, he was very responsible. He was not missing work. He was living alone, just being immigrated from a country in the south part sorry, my words. So it was Guatemala. I was just kind of thinking it was a south country. But anyway, he just immigrated. So he was living alone, was coping at night while drinking, which he thought it was just relaxing. But then on the weekends, had nothing to do. He was isolated, didn't know a lot of people. So he was drinking more. But again, he was so responsible because one of his big values was to send money to his family. So he thought, this is not a problem. I'm really sending money to my family. I'm meeting my goal. I'm not missing work. I'm functioning well. So if we had not given that screener to him, it will be someone that we will go, we will not even recognize that he was facing an alcohol problem. When we select the screener, we realize he was drinking a lot, and we start the psychoeducation there with him. So that's an indication of how important it is to use these screeners, because they will guide us of things that patients probably will not report. So this is the alcohol again, and they're there for your reference on the slides. If we go to the next slide, this is actually the drug abuse screener, the DAST. Now the DAST, and if we click again, is going to show the other version. The DAST has two versions. So on your right, you're going to see the long version, which are 28 items. And then on your left, you're going to see the short version of the DAST, which is 10 questions. So for clinic flow purposes, in the clinic I work here in Wisconsin, we do the short version, which we have recognized that it gives you a lot. It gives us really the information that we need. And just with those same questions, people, answer them, and we can have an idea of how they're doing with the use of drugs. Between the score of 3 and 5, it's considered moderate, and we'll record just to investigate more and probe more. We don't do the complete task to kind of investigate more. It is more that the medical assistant, if they realize it's positive right away, because part of our clinic flow, it's that when the patient get roomed, we give these screeners once a year. So if it's flagged on the medical record that it's time for the patient to receive the screeners, the medical assistant will give the audit and the test. And if they recognize there's a positive score right away, they let the provider know. But that will also make them, the medical assistant will aware us that we, BHC, will need to go and talk to the patient. So again, if there's a 3 or 5, it's considered moderate, and that's when we jump in and to kind of find out what's really going on the life of the patient, how they're using the drug, since when, and all that, versus I will say putting the complete task, right? So we do that, and then also, like below, the way that you have to kind of score this, it's information that it's provided in your slide as well. Now, so that's the S part, which is the screener, right? If we go to the next slide, it's the B of brief intervention. So walking you through the system, let's think that we did a screener, it comes positive, and then it's probably good to start providing intervention to the patient. Now, the brief intervention looks very different depending the case, patient to patient. It can all start with inviting them to do some behavioral changes in their routine. It can be with giving them information for AA meetings. It can be even just psychoeducation, like the patient I shared that he was drinking too much, but he didn't know he had a problem. A brief intervention is just that psychoeducation, right? That we were providing and letting them know that actually, yeah, he was having an alcohol issue. Changing some of the routines. So for him, the brief intervention was a psychoeducation, providing some resources to get connected with other people from their culture, because he was very isolated, and create like new routines as to what to do after work, and particularly on the weekends. Another brief intervention that worked for him was identifying, because an important of his value was to send money to his family, how much money he was going to be able to send to his family if instead of spending on alcohol, he will not do that behavior that was unhealthy, but save that money, send it to the family. And what we did was, like, from that amount, or that math that we did of how much he was spending on alcohol, we split it. So half, it was going to be more money he was going to send to the family, and the other half was going to be invested on him, as to, gonna go and visit local places here in town, or get into, maybe go to the movies, or like doing something that he will, like, he was rewarding his work throughout the week, versus just relaxing with a beer at home. So just like you said, like I said, the brief intervention can look very differently depending on what's going on with the patient. But I will highlight that the big part, it's providing that psychoeducation. Another piece that I find myself providing a lot of psychoeducation, it's a woman. They think that because the threshold is kind of lower as to when it can come positive, a lot of women will not recognize that actually the amount of alcohol they're drinking is going above. And even just sharing the screen and letting them know, like, the scoring, in which is different from woman to man, can be very helpful for them. And they will say, I didn't know that. The other one that it's making me laugh right now, it's when people say, well, we live in Wisconsin, it's all about the beer with the games and the Brewers and the Packers, and and it's true. I mean, I think the culture of the state, it's very much involved, and socially it's okay to drink X amount of alcohol, but people normalize that. So the screeners can really, again, highlight and provide some psychoeducation to patients. So again, that's the brief intervention. Another brief intervention that we typically use a lot, and we can go to the next slide, which probably a lot of you will be familiar, is the motivational interviewing. So one of the things I'm very passionate about the integrated care and about these clinical pathways is because most of the time, our people who are struggling with alcohol and drugs, they're not there yet to receive treatment. So to place them on a waiting list or miss their appointments and taking probably spots from people who really are ready to be there or are motivated, it's really blocking the system, right? It's actually a waste of time and efforts. So a lot of the times when we do the screener and we realize maybe this patient will benefit from, being referred outside, we don't jump into doing that right away, because a lot of the times we start working in their motivational scale to allow them to be ready and move to a place in which then they can be referred out. So the motivational interview comes very handy in order to do that, to allow patients to create some changes. Another thing that I have found out in practice is that while we start working with the motivational interview skills with a particular patient, sometimes they do improve so much that then they don't need that treatment, get referred outside to more specialty care. So we can improve not just with, again, helping stuck of the system with specialty care, when we allow them to have some changes and then they move really well with the model of integration, or again, just move the scale of the motivational interview of their motivation to change in order to start treatment and be completely engaged in the treatment. So again, I think all of you are familiar with motivational interviewing, but I put here some of the key elements that we use a lot in our sessions. And again, these are things that we can do between 20 to 30 minutes. We like to express empathy as to why they're coping with an alcohol or a drug, and most likely is based on, it's a coping skill. They don't know how to treat whatever stress level is going in their life or whatever they're dealing with in a healthy way. So they're just doing this as a coping skill. So we express empathy as to, we understand, like, for example, going back to the example I provided earlier, that the patient was isolated, feeling alone, and for him, the only thing was, kind of to forget that there's the family and all that, and drinking alcohol. So expressing that it's hard, being an immigrant, being isolated, being alone, and that it at the moment makes sense that he was using alcohol, but that we were there able to provide other coping skills that were healthier for him, or actually healthy, because what he was doing was not healthy, And he didn't know. He didn't know there were resources. He didn't know there was actually a support group for Latino men in the community. So all those things just kind of, we remove the alcohol, but the coping skill is going to be different. And we allow this by expressing empathy. We want to make sure that in order to move the patient in that motivational scale, we need to be open without any judgment. Develop the discrepancy, like the discrepancy of the case that I just explained was that, well, he was here because making the sacrifice to be in this country to send money to his family in his hometown. But the discrepancy was that he was spending a lot of money on alcohol. So that was taking away of his main goal of supporting his family. So when we were able to place that out for him, it was clear that he said, oh, I can actually do better in my main goal, which is sending money to my family members, but just changing that unhealthy behavior. So you place that. Avoid argumentation. Sometimes people are not ready to change and they're very defensive as to, no, I don't have a problem, or you don't understand. So we want to definitely avoid that and instead roll with that resistance. And again, just kind of get more being more curious and have more curiosity as to why they're doing that behavior. I always tell my patients, they know because I say, I know it's alcohol wrong, I know it's bad, I'm not going to do it, or drugs, but reality is they're doing it. So I always let them know, yeah, but I'm sure the alcohol or the drug is giving you a benefit in some way, either reducing your anxiety or calming you down or forgetting about something. So what is the benefit that you're getting? And when you're able to allow them to discover that, it's easier for you to help them identify another coping skill that would allow them the same results, right? So going back again to the example, if this guy was feeling alone and isolated and alcohol just make him forget, well, when I was able as a provider to understand that that was the motive or that that was the benefit that alcohol was giving to him, it was easier to give other solutions that will substitute that unhealthy behavior. And then support their change. So when he came back and he was doing really good changes, just supporting that as they're going along. So motivation interview is super helpful as that brief intervention together with the psychoeducation. If we go to the next slide, we're going to go back to the refer to treatment. So we did the screener, we identified a problem, then we did the brief intervention. Again, we have to do a lot with psychoeducation, motivational interview, and maybe other resources and stuff. But then we decide, okay, after all this, I think actually this patient does need more intensive services. And that's when we can refer outside of your site or your clinic. Now, these can look very different depending on your hometown or the resources or the insurance of patients and things like that. But you want to make sure as a provider that you are doing that referral when the motivational scale of the patient, they're ready to go into that change. If we just refer out and we know that there was a lot of resistance, we were kind of probing and talking to the patient, probably we're gonna end up with what I shared earlier, getting somebody stuck on the system, making the waiting list longer and not getting really the benefit of that change. So I just kind of explain again the meaning of SBIRT, which is the screening, the brief intervention, and refer to treatment. I have to tell you that from all the people that we screen and we start the brief intervention, a very high percentage, we don't need to refer them out. Like when they're ready, or we continue to help them in that motivational scale, we do a lot of benefit as providers. And then again, yes, we do refer out, but only for those that we feel they're ready or their life is in some way at risk. Now, because we work very together with the providers, for example, for someone who's drinking a lot of alcohol and we're concerned about withdrawals or anything like that, it's very convenient for us, or at least for me, for a mental health provider, that I have the support of my primary care doctor to work that process together as to how we can best support this patient. So I feel like back up that we can create a a program together that will best benefit the patient, even when they're having a high amount of alcohol or they're very dependent on it, and how to work on it. So I just walk you through and even give you an example of how Spread will look like and an integrated program that is using it. And again, each clinic will have their own flows or parameters, but we do this at least for all our patients, the screeners, once a year. Of course, if it's positive, then we follow up closer. But the minimum for each patient is to receive the test of the 10 questions and audit once a year. We can move on to the next slide. And please, if you have any questions or comments, feel free to either unmute yourself and interrupt the presentation. I'm happy to answer the questions or write it on the chat. Now, the MAT, it's another clinical pathway. It's the medication assistant treatment. Now, this is going to be a pathway. We can go to the next slide, in which really there's going to be more support to those patients who have some issues with medication, particular pain medication like the opiates, right? So we combine that with behavioral therapy and medication, some medication that will help with those substance use disorders. We tend to see a lot of people who are like in drug use, but then we start, we use medications like the methadone, naltrexone, and Suboxone to help them with that. In order to bump into this program, I think it's important before you run it out to create a protocol of how this will look like in your clinic, because you're going to be dealing with maybe often, screeners like labs on patients just to make sure if they're using or not drugs, what is the policy of the clinic, and things like that. So these clinical pathway, I think it has to be more intentionally think about if you're going to implement that in your clinic. Let's go to the next slide. So one of the things that you want to make sure is that the provider has a complete training and has received the waiver to prescribe those medications. As you know, they're controlled medications, and it's important that the provider feel comfortable prescribing those medications. Once so again, if in the clinic you realize you're going to create that protocol and you have providers that feel comfortable, then I will say, if we go to the next slide, it's very important the collaborative work that you're going to be doing. So this is going to be looking very much like the integration, right? In which you have your provider, but you also have your BRTs working together, but it's also collaboration in which you need the patient to collaborate. So I'm going to walk you through what we do in our clinic with our MAT program. So we recognize we have providers that feel comfortable and they are eligible to prescribe those medications. There's a BHC, a group of BHCs who feel very comfortable working with these patients. But the other thing is that there were a lot of clinical flows that were created. So there was an agreement that it was created that the patient will sign as to if they start in an MAT program with us, what things they were gonna expect that it will happen, right? Like checking like urine tests or blood tests and things like that, how often they need to come. And then what were gonna be the issues if the patient will not follow those, if we were gonna stop providing those medications or not. Now that protocol was created very much together between the BHC, the clinical manager, and those providers who felt comfortable prescribing those medications, because it has to be very well thought about, in that if you're going to start providing those medications to some patients but that they don't follow those kind of steps, what do you need to do if they don't follow without putting at risk their lives? And we also have to take into consideration that a lot of these patients, when they're sometimes they come across with other mental health struggles, like for example, personality issues in which they're fighting, they're angry, or they call you and they said, I want more medication. So what to do in those cases? So it's important to have those scenarios be planned there, and have just some forms that the patient will know exactly how it's going to be, but also for the providers to know if they run into X or Y scenario, what is going to be the clinical way they're going to react based on what the clinical manager agree, and the provider and the BHC, etc. So it's very important to have those protocols. So again, that protocol is in place. So what happens is one of our providers will see a patient, and they will recognize that there's a patient that will really benefit from the MAT program. So what happens in our own system is that we have a referral form. So they will let BHC know, hey, I have John with me, and I think he will really benefit from the MAT program. Oh, great. So then I go in as a warm handoff and see John, and I start asking, I just talked to your provider, and it seems like he told you about our MAT program, and that you are open to, work with us on that. So we have an intake form, and we start asking some questions. Now, with that intake form helps our special provider, who is able to prescribe these type of medications, understand a little bit of the history of that patient, right? If they have any comorbidity issues or anything that we need to be aware of. Then we let them know that they will receive a call from scheduler in order to come and talk to that provider that feels comfortable prescribing those medications. So the provider that is licensed to prescribe these medications will review that intake form, and then we'll say, yeah, I think this is an appropriate patient that we can see in here. So that patient gets scheduled, and the first meeting always is with the provider first, and he explained everything, how it's going to work with the patient, and then is referred to us again, so we can start working with those behavioral strategies. And one of the things I like to tell my patients is that this program and actually everything, it's going to be like a puzzle that we need to complete. So the medication is one part, behavioral changes, it's another part. And then coming to the sessions is another part, and then having labs is another part. So it's a puzzle they have to complete. They cannot just come, get their medications, and leave, right? So we start working also with behavioral, helping them adjust those life changes behaviors, that it's important to allow them to have that change. And we start working with them. Once there's follow-up with them and they're moving forward well, they don't always see BHC, because if they're doing well, they can continue just coming for those refills or things like that. But again, I will say that these can look very different clinic to clinic. Now, one of the things, if again, you're thinking about this will be something that will benefit in your clinic, and you feel like, okay, who can help us if we start this? Where do we start? Those are things that you can bring on in our one-on-one sessions that you guys are eligible to use with us. We do also have MAT from the provider side, but also from the BH side, that they just do this in their role, and they're experts. So we're happy to, facilitate conversations with them if that's something that you feel your clinic will benefit for. So that's the MAT. Now let's go to the next slide. Now here, again, I think this slide was presented to all of you guys in our first sessions, but this is a really clear indication as to you can run different, two models in one clinic and different models, right? So this is just like an example of a patient in which he was invested in these three models, in the PCBH, SBIRT, and the COCM. And it's described there as to what was the role of the PCP, the BHC manager, and how, that looks like. Or, because with the COCM, you also have the consultant psychiatry, so it's also involved there. But sometimes it all starts with having just the clinical pathway of the SBIRT, in which you have the screeners, and that's where you identify an issue, and then, that patient gets seen by your BHC, and then if that patient, let's say, has, depression, anxiety, and you happen to have COCM in your site, then it can go move to that list as well. So yes, these models and clinical pathways can be worked together at once. However, I'm going to really, really emphasize, and that goes to our next, but then again, this is the map of just 14 weeks of how that will look like. But if we go to our next slide, I want to really emphasize that if you don't have nothing related to integration in your clinic, it will be a huge mistake if you want to jump into having two models or having two clinical pathways at the same time. I will highly recommend to start with one, and then once that is really strong and firm in your clinic, and you have identified the hoops and loops that had to be changed in your site, then it's safe to say we can incorporate another one. Because a lot of the times you can think, oh, well, we're doing. So one of the things that we find when we do a TA is that people will say to us, oh, we're doing integration already. We're doing, I think, PCBH, right? But really, when we start looking at it, they think that integration is having a mental health provider in the same building. And that's not really what it is. That's an allocated mental health provider. Integration really means that really your mental health provider is working side to side with the providers. They're sharing the same rooms. They're having similar schedules. There's warm handoffs. So a lot of the clinics that we support, they'll say, oh, we have warm handoff, but the providers will place those on a schedule. Well, that's not a warm handoff. That's really scheduling someone on a slot that it's open. So really what we have found out with our TA services is that once we start engaging with a site, the idea of integration can look so different in many different places and very much away from these models that you guys have been learning all these months, PCBH or COCM. So if there's nothing in your site and you want to start something, I will recommend starting just with one model at a time and make sure it's really well, established, and then keep adding. I can tell you that we have been doing here in the clinic that I am in Wisconsin, I think over 15 years with the PCBH model. So it's really strong. And we are just going to rule out a pilot in COCM and see how that goes, right? We have things of the PCBH because we have a consulting psychiatry already that really embedded really well or will help the COCM get run through. But even though we have a lot of things already and the culture of the site is already mature to understand and make the correct referrals and all that, we're going to start very conservative because it's so easy that things can get broken. If we say, oh, let's just start COCM right from the top, all out, full out, probably what would happen is that the PCBH will suffer too, and we're going to start drifting a little bit apart of the fidelity of the models. So also I have to say that it's hard. It's hard to have 100% of fidelity in all the models, but what you want to do is to really recognize the things that are not allowing you to be very close to the model and start fixing them. And if you jump too high trying to do everything at once, it's just going to collapse. I mean, we have known that for experience. One of the hardest things that we identify, it's the changing of the culture. So when you don't have integration and you're just going to start just changing that shift and that culture is really hard. This morning, I was having a site TA session with 2 new BHCs on a clinic. Now, this clinic started integration, I would say 6 years ago, but there has been a lot of turn around regarding their BHCs providers. So just with the own turnaround of the own BHC department has affected the fidelity of the model, even though they have PCBH for years. So while I was training these 2 BHCs, one really gets it, and it has been the only thing they're doing. So he really gets the PCBH model. But the other one really started to work in the integration because she thought it was good, like it, but is really struggling because her mindset, it's really into the specialty care area. So some of the things that look so normal for a very natural BHC, she gets stuck. So today we were having the conversation as how do you treat couples therapy in PCBH? And I talked to her, it's the same that you do if you have a patient with a family member. You want to help that patient function better or that couple function better. But she was really stuck in the idea that I can't see the partner because I've been seeing the woman in this case for several months. So it will not be helpful now to see the partner, right? But again, she was thinking very specialty mental health, which usually when you go to individual therapy, it's not the same therapist you'll see if you go to couples therapy. Usually it's different, right? So she was very stuck on that thought, and it was hard for her to understand how it was okay for her to see the partner. And again, with the mantra that we have in these integration models about the functional assessment to function better, that she was going to help them to function better as a couple. So that's why I'm bringing this up to let you guys know that it's very important that you start on baby steps. And because one of the hardest thing is that culture shift, not just even in the clinic, sometimes at administrative level, sometimes at provider level, but also with the BHC sometimes. If you have new BHCs or people that have never experienced that integration, it really requires another way of thinking. So if we, for example, implement the MAT or there's BIRD clinical pathways, and we have BHCs in a very traditional mindset, they're really gonna struggle, for example, to give recommendations for treatment or to do that brief intervention. They might want to refer everybody out instead of working with them in that motivational interview, track and helping the patient and psychoeducation and things like that. So that's why it's important that you first, when you're gonna implement, review how is the clinical your culture and how best to do that introduction. And that's why I also wanna keep inviting you that's why it's important to have these one-on-one sessions with us, because you can talk to us as to what is going on and we can guide you as to how you can do this. So start a model one at a time. It's really hard to get that buy-in, so that culture shift, it can be complicated and difficult. Now, like I start my presentation today, which model will be the best? I guess my question will be back to you and say, what type of question you want to answer in your site, right? Now, I will really recommend not to have the question, what gives us more revenue? Because that's a way of starting backwards. When we start thinking about what is the one that gives us more revenue, we're probably not going to be it's going to fail. If you start asking, well, I want to increase, accessibility, or I want to improve, this particular group of patients, or I want to start identifying which patients need further treatment for alcohol or drug. When you start asking those type of questions, the revenue falls into place very nicely, and the same, I would say, value or energy that you have to resolve that issue in your clinic for the population that you're serving, automatically the revenue will come back easily. But if you are seeing this with a business mind, thinking about what gives you more money, it's going to be hard because you're starting backwards, right? So in all of the models and stuff, they have their tricks, I would say, in regards to billing. And I think we also mentioned this in our session of billing, that you have to be very creative as how you want to play the system, because reality, the people that write the rules for billing are not clinicians, are not the people that are in the clinic. So there are a lot of things that they're not seeing that you as a provider or even administrator in a clinic are seeing that your clinic is dealing with, right? So again, if you want to identify the best model, first ask what type of question you want to answer, resolve in your site, in your clinic, and that can give you a better indication as to how to continue to move forward. So again, I will highlight that the integration, when you hear the word integration, it's important to ask first, how does that look like? because having a mental health provider in the same building, that's not integration, that's an allocate service, right? And then if that service of that mental health provider, it is to have scheduled patients, what's going to happen is that pretty fast that mental health provider or providers will have their agenda full really quick. And then there's not going to be spots to schedule more patients, right? Because it really is just the section of your site that is doing traditional mental health therapy, which is good. I don't want to send the message that this is wrong or bad. It's just not integration, right? And one of the downsides that we see, that's why integration came into the place, was that the traditional mental health service, it's helpful, but it gets booked really, really fast. And lastly, I just want to end with comparing or the analogy of, as we need, doctors in the emergency room, we need those doctors, right? Because you have emergencies and they're always working fast, 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 fast. They don't know how their day is going to look like. It's unpredictable. They need to help the patient serve their lives in the moment. And then later they will refer that patient to maybe their medical home to check cholesterol or other issues. But in the moment, it was about the heart attack, for example. It's very similar to VHCs and traditional mental health providers. The VHC, it goes fast, 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 unpredictable. You don't know how your day will look like, but you want to help the patient in the moment to function better, right? Now, if we feel or the patient wants to really go into trauma and their past and their childhood, well, that's something that they can do with a traditional mental health person. But our role is to help them to function better. So if they cannot go to work, how can we help them start working, right? If they're not taking their medication, how can we allow them to start, working in their medication? So it's not that it's a short intervention, it's just different, right? We don't say the role that an emergency medical doctor does is short. No, it's just different, right? And we need both. We need the family doctors who it's more predictable. They know what they're going to be seeing with their patients. And we need also the emergency residence doctors, right? It's exactly the same with the mental health providers. If you are a BHC, your role is just different. And what you're going to accomplish with your patient looks different than what would be in specialty mental health as providers. So we can take the slides just so we can see each other faces as we're kind of ending with 10 more minutes of our session. But I just want to walk you through all the sessions that we review and kind of connect the dots. So we started just with putting everybody on the same page, learning the languages, what are the models, and explaining the very basics. Then we went with the base. We talk about some tools to identify where you are where your site is located in that spectrum of integration. For those sites that have nothing regarding to integration, we talk about the PAP, and that's a tool that even though you feel there's nothing about integration, there's always a little tiny thing that there's an integration. With that tool, what happens is that we are able to elaborate and grow and say, well, these are the things that I want you to keep doing, and these are the things that need to be different. It's just to assess your site. Then we kind of talk about your staff development, how you hire a BHC, what are the skills that the BHC should have, and then how to get the buy-in in your providers and the clinical environment. Then we jump into documentation. Documentation looks very different for BHCs. It should be short, it should be not time consuming, but very specific and to the point. And so we did that also in one of our sessions. And then we jump to the billing part, which I know a lot of you are very interested. And that's when we talk about it's very important to be creative in the rules that you are facing or the insurance that you are having in your site. And something that I will point out here is that it's important sometimes to even just check data. Like, what is the main type of insurance that your site is covering? Because that can help you answer a lot of billing questions. We talk about tools and workflows that we can do in the clinic and how to measure those. So it's important that we keep that data in track about maybe how many patients you're seeing, what type of, usually the patient that you're seeing or which provider is giving you more patients, because that data helps you create stories of what's going on your site. And with those stories, you can ask for grants, ask for another position. So those will help you justify your program. So we mentioned that, we talk about metrics, how to kind of check those. And then we're jumping into the other model of COCM and how consulting psychiatry will look like with the very COCM model, or also just having an consultant psychiatry and how that can support your clinic. And we move more into pediatrics, how would that look like, chronic disease management, and we kind of talk about workflows that you can create in your clinic. And lastly, today we ended up with substance use. So I really hope all these sessions have opened your view and make your wheels spins as to what things you can use on your site. Some of you, I know, they're really advanced in your integration. Others are just starting. Others have not even started. Others are struggling with what you guys are dealing with. So even though you all are different stages, I hope this information has been helpful. And again, there's still funds allocated for those one-on-one sessions, so use them. And it's as simple as just emailing me, and then we can schedule something on Zoom, and we will be able to help you with that one-on-one individualized support. That's all for me today, but I want to open it to questions, comments, and I don't know, Jen, if you have any other announcements to make.
Yeah, no, I just want to make sure everybody saw my notes in the chat. If you're a psychologist that was seeking treatment, please email me. I want to say thank you again to Martha, and Naftali's not here, but I'm sure she'll pass it along to him also. We have a lot of exciting things coming up in this project still. There's the one-to-one consultations that you guys are going to have available to you. We'd like to do follow-up with all of you in a few months to talk about where you are with integrated behavioral health, and if there are other things that you need. We have an upcoming meeting with the Wisconsin Psychiatric Association and some of our integrated behavioral health experts in the system to talk about how they can lobby for some funds or lobby for changes in how integrated behavioral health is paid for in Wisconsin. So they're going to be working with WCHQ over the next several months to talk to us about what they can do to support all of you doing integrated behavioral health in your clinic. So there's a lot coming up. We want to stay in touch with all of you, and we want to hear what you want next. Are there things that you, in 6 months, you say, you know, Jen, we really need training on this, or we really need refresher on this? I want to hear from you because we want to do what it takes to make sure that you guys have the tools that you need to either increase integrated behavioral health in your clinics or to start integrated behavioral health in your clinics. So that is all.
And also, Jen, didn't you share also in one of our sessions that you guys have the ability to help people with the data?
Yep, we do. And we actually did a session, and Abby is going to be doing data with all of the participants here. She met with them, and she's going to be pulling together some data that she's going to share with them, and then they can ask for different data or have it looked at differently. We're going to continue those conversations over the next few months too.
Awesome. I will really just continue to emphasize to everyone to use the resources that are there through WCHQ. It's just a way to make your life easier. So reach out.
Does anybody have any feedback or questions or anything they want to say? We have a few minutes left.
Thank you, Michelle. Thank you, Katinka. I'm glad to hear that it has been helpful.
Well, thank you, everyone. You get 5 minutes, 6 minutes back in your day, and we appreciate all of you participating in this 12-month webinar series. We are also going to be posting on our website in the next couple of months all of the links to the webinars as well as the slides, and we'll have our videos from the patients who participated in telling their stories. So all of that's coming up.
Bye, everyone.
Bye, everyone. Thank you.
Thank you.
Thanks, everyone. Oh. Yes, you had a question, Corinne? Nope, she must have raised her hand by accident. Thanks, everyone.